You are welcome to my channel. Thanks for visiting. Please remember to subscribe. But if you are subscribed before now, I'm saying a big thank you. Today is all about infective endocarditis. I will just start with the definition of certain terms and then go over the risk factors. I will publish more topics on infective endocarditis. Without further ado, let's check the anatomy and definition of certain terms and risk factors when it comes to infective endocarditis. You can see this is the structure of the heart, right? But we're looking from the outside. I could see some blood vessels. The heart wall has three layers. The innermost is endocardium. The main heart muscle is called myocardium, while the outermost, protective layer is called the epicardium. I'll go into details in a bit. Before going into full details, let's quickly check through this section. So I've shown you the model of the whole heart the other time. Now, cutting through, we could see that we can see the inferior vena cava, the superior vena cava, bringing content into the right atrium. This is tricuspid valve, right, between the right atrium and the right ventricle. And this is pulmonary valve, opening into the pulmonary trunk. And that is going to, the lungs, pulmonary artery. And you could see that this is the right ventricle, right? And this is the wall, the myocardium. You can see that. And inside the myocardium is the endocardium. And outside here is the epicardium. I will go into details later. If you want to know more about how the heart is pumping the blood, I've made separate presentation on that, published under atrial fibrillation, schistosomiasis, heart attack, and the list goes on. So you can check my channel for that. Detailed explanation about heart wall layers. Our goal is about endocardium, but we can't just get there without going through the entire layers. The heart is in a sac, pericardial sac. The pericardium has different layers also. The first part of the pericardium is the fibrous pericardium. Then the next layer will be serous parietal pericardium. And then there will be a space before we will reach the serous visceral pericardium. The space between the serous visceral pericardium is pericardial cavity. That is the space. That is a story for another day, because when we are dealing with pericarditis, we'll understand better. The serous visceral pericardium is also known as epicardium, and that is the first layer of the heart wall. Okay? Epicardium is also known as serous visceral pericardium. Above it or outside it is the pericardial cavity. When we are dealing with pericarditis, we'll talk more about that. Then the next layer going in from epicardium is the myocardium. Now, let me talk a little bit more about epicardium here. Is the innermost layer of the pericardium, but it is the outermost layer of the cardiac wall. It has protective effect for the heart muscle. It has mesothelial cells. It contains fat and connective tissue. So that is all about epicardium. Myocardium is the rhetic muscle. Myocarditis will lead us to full information about that later on. Now, for the topic of the day, the endocardium. That is the innermost layer. Innermost layer, when we are going from outside down inwards, the endocardium is very thin. It is smooth membrane that lines the inner surface of all the heart chambers and all valves. It covers the heart valves. It is continuous with the inner lining of the blood vessels. Or, in summary, we can put endocardium as a serous membrane lining the heart cavities and blood vessels. Or you can simply say that it is the innermost layer of the heart wall with endothelium and connective tissue. Here, the endocardium is helpful by serving as barrier between the heart muscle and the blood that is flowing through it, or the barrier between the heart muscle and the bloodstream. So that is why whatever we will be saying henceforth will be very important as per what will happen when anything gets into the blood and flows and reaches the heart. Remember, it's covering the heart valves. So we will know when prosthetic valves is a problem, when native valve becomes infected, when and somebody gives injection or intravenous drugs use, bacteria is inoculated. How would that cause trouble? Here is because the blood will flow to reach this very layer called endocardium. Since we cannot be suspecting every patient that comes to the clinic to have infective endocarditis, then we need to know when to start suspecting that someone is likely going to have infective endocarditis. So 3 things will be considered. Number 1, the symptoms the individual will present with. Here, I don't need to go through the list of the symptoms because it is not going to be specific to infective endocarditis. Something like fever, chills, flu-like symptoms, night sweat, chest pain, arthralgia, myalgia, shortness of breath, edema, the lower limb or abdomen, then new heart murmur. None of them is specific to infective endocarditis. But something will be closer to pointing specifically to infective endocarditis, and that is on physical examination. We'll check the hand. When we check the hand, then we can see the heart through the hand. We'll look for Osler's nodes, that is for peripheral stigmata of infective endocarditis. We'll look for Osler's nodes, Janeway lesions, sphincter hemorrhages. We can pick petechiae, might not be limited to the hands in that case, or rod spots. So that will be pointing to, is likely. Then we will go through possible risk factors, which will be the core of this presentation today. We'll go through the certain risk factors. If we can pick one or more in that individual, then the next thing is to have full history, full investigations, both laboratory, radiological, come down with full diagnosis or definitive diagnosis and start treatment. So let's check the risk factors. Now the risk factors. The age. Normally, we would think the older we become, the more the possibility of infective endocarditis, and that is right. Age greater than 60 years, yes, we can be suspecting infective endocarditis, but we should not make that mistake. Infective endocarditis can be picked even in children, although not very common. We'll consider the gender. Well, very close, male to male, very close, but a little bit more in males. Like ratio male to female will be 3 to 2. So pretty close, but more in male. Now, the IV drug use. If we are fortunate that the patient is forthcoming to furnish us with that history, that would be pretty helpful because IV drug use now appears to be the most preventable cause of infective endocarditis. Germs, particularly bacteria, from unhygienic environment, needles, or dirty skin or contaminated wound on the skin, and you poke through, or even from contaminated drugs itself, can get into the system. So when you inject and you send in whatever into the system, you are sending that with the bacteria or fungi that could cause infective endocarditis. And remember, infective endocarditis could be caused most of the time, 80% of the time, by the bacteria. The right heart will pick whatever you're sending and it's going to go through the right atrium from the inferior vena cava or superior vena cava to the right atrium. The right atrium, the blood will be pumped into the ventricle bed over the tricuspid valve. So whatever you are sending in, then that could be a problem for tricuspid valve in the right heart. And remember, it will go into the lungs also, giving us pulmonary embolism. So when it comes to the HIV, whatever history that is pointing to HIV and the screening is done and the individual is HIV positive, well, it's likely that the source of the HIV might be IV drug use, and also HIV could lead to immunocompromised state. Now, like I have explained, the IV drug users will get whatever jam into the system when they inject the drugs. Even the drugs themselves could be contaminated. So that will come through the vena cava, the superior, inferior vena cava, then to the right atrium. So the jam will then come here. This is inside the heart, right? So the endocardium is there, and the endocardium is covering the valves also. Then the jam can rest here. And we then have infective endocarditis from poking or getting needle into your arms that is contaminated. Still on risk factors. When we come across an individual with previous infective endocarditis, now with signs and symptoms, with peripheral stigmata, we can then do the rest workup. It's likely going to be a repeat. Then in the case of hemodialysis, not in anyone having hemodialysis immediately, not in acute care, but chronic hemodialysis, the process of setting up the IV access, it could be contaminated, and when it's kept for a long time, like indwelling catheter, right, possibly from chronic renal failure. And then remember, chronic renal failure will also lead to immunocompromised status. So immune-compromised status is a great ground for microbes to grow, right, to thrive, okay? And then through the IV lines, there can be seeding of those germs. That's why hemodialysis, chronic hemodialysis, could be a risk factor. Another risk factor would be congenital heart defects. let me leave the note here that not all congenital heart defects will be a problem in childhood. Some could be tolerated till adulthood, but when it comes to infective endocarditis, we'll be concerned about aortic stenosis, patent ductus arteriosus, coarctation of aorta, and tetralogy of Fallot. The tetralogy of Fallot will be 4 items. Remember, tetra, 4. So, right ventricular hypertrophy, ventricular septal defect, overriding aorta, and pulmonary stenosis. Then another risk factor could be valvular heart disease. Here we'll be talking about mitral valve prolapse, aortic stenosis or mitral stenosis, including rheumatic heart disease. When we find a patient with all these, in addition to peripheral stigmata and symptoms, then we can start the workup on infective endocarditis. This is just to review what I've just said on previous slide. So, like in tetralogy of Fallot, the aorta here will be overriding, and then the pulmonary artery will become stenosed, will become narrowed, and then the ventricle will become hypertrophied. And of course, we're going to see ventricular septal defect here. This is from the left side. This is mitral, like we were talking about valvular heart disease, that mitral valve prolapse. So this is it. And then this is the aortic valve. So we were talking about the aortic stenosis. And then this is pulmonary valve, right? And of course, tricuspid valve. Other risk factors will include certain invasive procedures like coronary artery bypass graft or insertion of intravenous catheter, including indwelling intravenous catheter, because while stuff will be sent through this route, bacteria or fungi could also be sent. Also, open cardiothoracic surgery. Well, the surgeons are pretty careful, so meticulous, but one way or the other, anything may happen, and then bacteria could get into the system. So, no, it is a possibility. Not common. No, not common. Also, uncommon will be cardiomyopathy, specifically hypertrophic cardiomyopathy. It's not very common, but it is a possibility. So we need to make mention of that. Another risk factor will be implanted devices. And I decided to match that with prosthetic valves because it's all the same when it comes to the risk of infective endocarditis. Someone is on pacemaker or implanted cardiovascular defibrillator. Well, it's not common, but maybe the source of infective endocarditis. Also, prosthetic valves. The surgery is there. The grandpa had aortic stenosis repaired, then the valve replaced, and so on and so forth. So that could be the risk factor. Like I've just said a while ago, like implanted defibrillator or pacemaker to enhance electrical activity, or you replace the valves, then you put the artificial valves here, then that may be the source. Another risk factor will be right heart native valvular disease. In this case, the blood from the head, the neck, and other parts of the body will return to the heart through superior and inferior vena cava to the right atrium. From right atrium, will go to the right ventricle. Remember, that will pass through tricuspid valve. So if the microbes are in that blood flowing through that direction, then the tricuspid valve could become diseased or infected. Then we have the native valvular disease right there. Lastly, dental care. I've decided to put this last. I know it's pretty important when it comes to infective endocarditis. The problem here could be dental infection. Yes, and that will eventually end up as infective endocarditis or poor dentition. And from dental care, maybe you are using toothpicks and you are poking the gum, or you are having dental flossing, affecting the gum, oral gels, or you are embarking on dental surgery or certain procedures. That is why when we start talking about prevention of infective endocarditis, we'll go through the list of agents that we can use prophylactically if anyone will have dental procedure. With that, I've come to the end of this short presentation on how infective endocarditis can occur and the possible peripheral stigmata with the risk factors. Thanks for listening. I will have more presentations on infective endocarditis. The next will be on how to make diagnosis of infective endocarditis. Please share this on your platform. I appreciate it.